Okay, well, that question about solid tumors is a great lead into the sort of switch in feeling before the break here, because we're going to have a talk now on something very, very different than liquid tumors, pancreatic cancer. And believe it or not, there is an immunologic horizon even for pancreatic cancer, as we're going to hear from our great speaker, Dr. Prakash Radhakrishnan, who is listed as coming from the University of Nebraska, but has just this month joined the University of Louisville. So actually he's now a Kentucky native. So he's going to speak to us about MUC16 mediated pancreatic cancer and potential immunologic targets. So I hand it over to you.
Yeah, good morning, everyone. And I would like to thank Dr. Robert Emmons for giving me an opportunity to share one of the projects, what we are doing in the lab. Like you all know that targeting cancers with an antibody is very tough because that target should be only expressed in the tumor cells, or it is overexpressed in the tumor when compared with the normal cells, or it has to be mutated only in the cancer, not in the normal cells. So today I'm going to talk about what is the target. Like the target is nothing, but it's we all know about it. Like CA125, it's nothing, but it's a MUC16. How we are identifying this as a target for pancreatic cancer treatment, and then what we are utilizing here is like an antibody-based therapy. So I don't have anything to disclose here. Why pancreatic cancer? So pancreatic cancer in the United States is like highly lethal disease all over the world as well as, and it is projected to be the second leading cause of cancer-related death by 2030. The 5-year survival rate is very low, like still it's in a 13%. Previously it was like a few years ago it was like 9%. Now it's slightly increased. It's a 13% right now. About more than 90% of pancreatic cancer or ductal adenocarcinoma, they are like exocrine when compared with the endocrine pancreas. The high mortality rate of pancreatic cancer is highly associated with poor prognosis, early metastasis, and one of the major reasons is like the development of the desmoplastic stroma and drug resistance. That's the most critical factor why most of the chemotherapy and immunotherapy is failing, and also like the immunosuppressive tumor microenvironment. According to American Cancer Society in 2025, about like 60,440 people will be diagnosed with pancreatic cancer. In that, about 51,980 people will die. So like the diagnostic versus the mortality rate is almost closer. That's why it's highly lethal disease, and it is proceeding to the second leading cause of cancer-related death by soon. The average lifetime risk of pancreatic cancer is 1 in 64. That is highly, we need to think about it actually. The current standard of care for the pancreatic cancer is like either nalinirifox or FOLFIRINOX and gemabraxine. So the overall median survival for with those drugs are like 11.7 months and 11.1 and 10.4, almost similar. But the problem is they all exhibit a different level of toxicities. When you consider for immunotherapy, it is unsuccessful right now because pancreatic cancer is highly loaded with immunosuppressive tumor microenvironment, like a lot of immunosuppressive macrophages and other populations. They were MDSCs and other populations. They were highly loaded in that tumor microenvironment. Again, like the immune checkpoint inhibitors, they were not as effective because either the normal cells or the cancer cell, they also express the immune checkpoint receptor ligands, so they can interact with each other. Then the T cells become exhausted. Recently, a promising thing like right now, the cancer vaccine, GVAX. So they are in the phase 1 to phase 2 clinical trial. Probably this will come up soon. We'll see how that is going in phase 3 clinical trial. Here the slide shows the morphological and genetical progression of the pancreatic cancer. It started from the normal pancreas into precancerous lesions called PANIN1, PANIN2, and PANIN3. Once it attained the PANIN3 precancer lesion, it started developing into pancreatic ductal adenocarcinoma. In this stage, it started to metastasize the other secondary organ sites. So in our lab, we are mainly focusing on MUC16. MUC16, like I said, it's nothing but CA125 is a diagnostic marker. MUC16 is like heavily glycosylated cell surface glycoprotein. It is about like 22,000 amino acid in length, and it's like a 3 to 5 million Dalton in size. It's heavily glycosylated extracellular domain. It has both N-glycosylation and O-glycosylation. Here is an example. Again, the MUC16 is like expressed in 50 to 70% of pancreatic cancer patient sample, and also its expression is associated with tumor progression and metastasis, and it's also closely associated with reduced patient survival. So what we did was we had opportunity to develop a rapid biopsy program in University of Nebraska Medical Center. We isolated pancreatic cancer specimens from the patient sample, and then we screened the expression of MUC16 at different stages. Normal pancreas to adjacent normal pancreas to pan in all the precancer lesion, ductal adenocarcinoma, adenosquamous cell carcinoma, and then and also endocrine tumors. So we do see an increased expression of MUC16 in the ductal adenocarcinoma and compared with the normal pancreas and other pan-in lesions. In addition to ductal adenocarcinoma, we also see expression of MUC16 in adenosquamous cell carcinoma and endocrine tumors. Here is an example like how the rapid biopsy program works in Nebraska Medical Center. We collect the patient samples in the morgue, and then we store it in the minus 120 degrees Celsius, and then we distribute it all over the world as well as to the domestic. We have homemade antibodies like AR9.6, 5B9, 511, and also we have commercially available OC120 antibodies against MUC16. We screen them, all the patient samples, and then we do see an increased expression and detection level with our homemade antibody called AR9.6 and 5B9 when compared with the commercially available OC125 antibody, suggesting that this antibody is finding more epitopes when compared with the OC125. In addition to primary sites, we also check the expression of MUC16 in a metastatic organ site, like one of the examples is liver. So we do see an increased expression of MUC16 in the liver metastatic sites when compared with the normal liver. Here is a heat map. It shows with the 3 different antibodies. The red color indicates that a higher expression in the liver mets when compared with the primary tumor. In addition to that, the higher level of the aberrant expression of MUC16 is also highly associated with reduced survival. And also we also see the short-term survivor has the highest level of MUC16 when compared with the long-term survivor. Next, we did a whole exome sequencing and RNA sequencing analysis to identify the expression of MUC16 is that it is highly associated with what subtypes. There are 4 different subtypes exist, adenox, ADX, and progenitor immunogenic and squamous. So with a different classification of Bailey and Moffitt and Collison, so we do see an increased expression of MUC16 is highly associated with aggressive tumor subtypes like squamous, basal, and quasi-mesenchymal. These are highly aggressive tumors. So with that, I'd like to summarize the part 1 of my talk. The aberrant expression of MUC16 is highly associated with epithelial origin of the tumors, and its expression also found in adenosquamous and islet cell tumors. And increased expression of MUC16 is associated with reduced patient survival. In addition to this, that increased expression of MUC16 is also associated with highly aggressive tumor subtypes. Next, to validate whether the MUC16 is really tumorigenic. It has a tumorigenic potential in addition to the diagnostic marker. For this one, we utilized a CRISPR-Cas-based system to genetically delete MUC16 in the cancer cells. And then here is a screening, we do see loss of MUC16 upon CRISPR-based knockouts. There is no expression of MUC16 in the 2 different pancreatic cancer cell lines by immunoblotting and as well as immunofluorescence. Next, we tested the effect of the MUC16 on the cell proliferative capacity. You can see that MUC16 knockout cells have reduced cell proliferation when compared to the wild-type cell. The wild-type cell has harboring the MUC16 intact. Always cell proliferation is associated with increased expression of cyclin D1 and cyclin E1. You can see there is a reduced expression of cyclin D1 in both the cancer cell lines. Next, we validated its function by in vitro and as well as in vivo tumor model system. In the in vitro, we did a cell migration and also a Biden chamber invasion assays. You can clearly see that when you knock out MUC16, there is a reduced cell migration and invasion in the Biden chamber invasion assays when compared to the wild type cells. And also, like when you implant these isogenic cell lines into the pancreas of athymic nude mice, you can see clearly that the wild type cells implanted tumor has increased tumor volume by tumor weight and tumor volume when compared with MUC16 knockout cells implanted tumors. So in addition to that, also like it shows a reduced tumor metastasis to the different organ sites like spleen, lymph node, and the diaphragm, and liver and peritoneal cavity. Usually MUC16 expression is highly associated with peritoneal metastasis in the pancreatic cancer patients, but we do see a reduced metastasis when you knock out MUC16. Next, do you identify what is the mechanism behind this, how MUC16 is driving all this tumorigenic activities? So we did a RNA sequencing analysis, and then we put it in the engineering pathway analysis. You can see clearly that in the MUC16 knockout condition, most of the epidermal growth factor receptor mediated signaling was significantly downregulated when compared with wild type cells, suggesting that EGFR pathway is highly activated. In order to EGFR pathways needs to be activated, either this receptor has to go for either homodimerization or heterodimerization upon ligand binding. So to validate these results, like we did immunoblotting on those pancreatic cancer cell line, you do see a decreased phosphorylation of phospho-ERBB3, phospho-ERBB2, and ERBB1, and its downstream target, and in two different pancreatic cancer cell line upon MUC16 knockout. And also we do see a reduced phosphorylation of AKT and the GSK3. These are the downstream target of EGFR pathway. To further validate these results, we also checked the expression of phosphorylation of EGFR and its downstream target AKT on the tumor tissue that is previously been implanted in the mouse pancreas. We see reduced expression of phosphorylation of EGFR2 and its downstream target AKT in the MUC16 knockout cells implanted tumors. To summarize this part of the talk, when you genetically delete MUC16, it reduces the in vitro and in vivo tumorigenic properties of pancreatic cancer cells. In addition to that, it also reduces the tumor metastasis, especially to the peritoneum and liver. And also, MUC16 knockout inhibits the activation of cell survival signaling pathway, nothing but it's a EGFR pathways. The third part of the talk is that's most important to hear, the immunotherapy. Antibody-based therapy against MUC16. If it is a good antigen, it should, like I said, it's supposed to be expressed only in the cancer, not in the normal cells. And also, it has to be mutated only in the tumor, not in the normal cells. So in this case, the MUC16 this is a primary tumor that shows the MUC16 expression. You can clearly see that it is highly expressed in the cell surface, and also it only overexpressed in PDAC when compared with the normal pancreas. Initially, we had a murine-based AR9.6 anti-MUC16 antibody that binds to SA domain 5 of MUC16, and it inhibits the abdominal growth factor receptor mediated signaling and reduces tumor burden. Here is an antibody that was developed by Quest Pharma DEC. They generously shared with us, and then we did treat with pancreatic cancer cell line implanted tumors. You can see that a murine version inhibits the tumor growth when compared with IgG and vehicle control, and also it reduces the tumor metastasis. When you look at them, when you look at the mechanistic angle, you do see a reduced phosphorylation of AKT and its upstream ERBB1 phosphorylation. We did a bit of mapping for this murine version of the antibody. It shows that it binds to SA domain 5 of the MUC16. This is a tandem repeat that presents extracellularly. So in order to translate this one into clinical, so we did a humanization of this murine version of AR9.6 with a CDR encrafted mechanism. And then we generated a humanized version of the AR9.6 antibody. And then we did a crystallization with this, and then we can see the Fab region of the murine version AR9.6 and the humanized are identical, and also it is very identical on the epitope binding as well. Next, we did epitope mapping studies with the humanized AI9.6. It also exactly binds to that ISA domain 5 of MUC16. So both murine as well as a humanized antibody, they binds to the extracellular domain tandem repeat of 4 and 5. In between that, it's called ACA domain 5. So next, to validate whether it can bind to MUC16 in the human cancer cell line as well as tumor tissues and PDX tumor-derived tissues. Here you can clearly see that the MUC16 antibodies only binds to the MUC16 expressing PDX cells, not in the MUC16 not expressing cells. And also we also got a PDX-derived patient sample. You can see that MUC16 positive cells only stained with this antibody, not the normal cells, not the normal tumor. And also we tested in the normal pancreas as well as in the PDAX samples. You can see clearly that this antibody stains the PDAX patient sample, not the normal pancreas. Next, we treated with cancer cell lines to see whether it can reduce the cell growth. You can see that HUA9.6 treatment in a dose-dependent manner, it inhibits the cancer cell proliferation in the 2 different pancreatic cancer cell lines. They were positive for MUC16. Next, we also did the in vitro scratch assay, whether this antibody can inhibit the cell migration. So you can see clearly that HUA9.6 antibody treatment that is significantly inhibits the cancer cell migration when compared with the isotope control and vehicle control treatment. To further confirm this migration assay, we also did a Biden-Champer matricial invasion assays. You can clearly see that a very significant inhibition of cancer cell migration through the matricial invasion, suggesting that this antibody is very potent and inhibiting the in vitro tumorigenic properties. Next, to further confirm this antibody's ability to inhibit the cancer cell growth, so we did a colony formation assay. You can see that antibody treatment significantly inhibits the colony formation in pancreatic cancer cells. So to translate this finding into clinical, so we also isolate cells from the PDAC patient sample and then develop into patient-derived organoids. And then we treated with humanized AR9.6 in the MUC16 positive organoid patient sample. You can clearly see that it is significantly inhibits the cancer of organoids growth when compared with the vehicle IgG isotope control and vehicle control. So as we know that the murine antibody also inhibits EGFR activation and the downstream target. So the humanized antibody also inhibits this activation of abdominal growth factor receptors and its downstream target in the cancer cell line as well as in the organoid treatment. So to further confirm this result, we also developed a primary and a metastatic patient-derived xenograft model. And then we treat them with this humanized AR9.6 antibody and also human IgG antibody. You can clearly see that antibody treatment significantly inhibits the phosphorylation of ERBB3, ERBB1, and its downstream target FAK and AKT. Next, to translate this into the clinical, like before that we want to do in a preclinical model, like we did on a subcutaneous tumor model. In there we treat them, we subcutaneously implant the pancreatic cancer cells into the athymic nude mice, and then we treated with vehicle control and the humanized AR9.6 and measure the tumor growth over that period of time. You can clearly see that the antibody treatment inhibits the tumor progression, whereas the IgG control treatment it increases the tumor growth. So as a downstream target like a K67 and CD31, like a proliferation and the cell blood vessel intensity, they all significantly lower in the antibody treatment. To further confirm whether it can also inhibit the abdominal growth factor receptor activation in these tumors, we also see that reduced expression of reduced phosphorylation of ERBB3, ERBB2, and ERBB1 and its downstream target AKT in those tumor tissues. To next, like confirm in a more clinically relevant model, like orthotopic tumor setting. So here we orthotopically implant pancreatic cancer cell into the pancreas. Then we treated with a vehicle control human IgG and HUA9.6. And then we let it grow for over 28 days. Then we sacrifice the mice. You can clearly see that HUA9.6 treatment significantly reduced the tumor growth when compared with HUA-IgG and vehicle control. by tumor volume as well as tumor weight also reduced. So in addition to this, like antibody also exhibit antibody-dependent cellular cytotoxicity and complement-mediated cellular cytotoxicity. So we also tested in that angle as well, when you treat cancer cells in the presence of PBMC, you can see clearly that antibody, in the presence of antibody plus PBMC, you can see enhanced cell death when compared with only PBMC, and also validate these results with the MUC16 knockout cells. You can see there is no difference. And also similarly, there is no difference in the CDC cell death if the MUC16 is not there, suggesting that this antibody can inhibit the tumor growth via abdominal growth factor receptor activation, and also it can induce the cell death via ADCC and CDC. So two different mechanisms. So with that, I would like to summarize the third part of the talk, anti-MUC16 antibody, both mouse version as well as the humanized version, binds to MUC16 through the conformational epitope called SCA domain 5. And upon binding, it inhibits the tumor growth in the in vitro PDAC cells, patient-derived xenografts, and in vivo tumors by blocking the abdominal growth factor receptor activation and its downstream signaling cascades. And also, it inhibits the tumor growth via inducing the ADCC and CDC. Finally, I would like to thank my lab members from the University of Nebraska Medical Center, as well as University of California, Fresno, from Dr. Corey Brooks for the humanization of the antibodies, and then the initial mouse version of the antibody provided by Quest Pharma Tech, and then also rapid adoption program from University of Nebraska Medical Center, and my financial support from National Cancer Institute and American Cancer Society, and recently Brown Cancer Center from University of Louisville. Thank you. I would like to take any question if you have. Please.
Thank you for this talk. I don't know what others feel. This is basic science, which is complicating and challenging, but I think it sounds promising. That's a great target. My question is, are there any phase 1 studies looking at incorporating this into treatment?
Yes, we are in the near future. We are going to conduct a phase 1 clinical trial here. Like we did the humanization of this antibody. We are going with a GMP grade facilities. We are talking about it with Dr. Emmons, so we can generate GMP grade antibody, and then we are planning to go for a MUC16 positive patient sample. We are thinking.
And this would be adding this drug to standard of care treatment?
In the future, yes.
Okay, thank you.
In addition to that, we are also thinking for the CAR T, like a targeted CAR T cell therapy.
With the vaccine?
Yeah, with the Yeah.
Thank you.
Yeah, yes.
We know that a BCMA is seen on all malignant plasma cells, 90-95% expressions. At diagnosis, at relapse, is involved in the proliferation, growth, survival. MUC16, is it only seen on malignant pancreatic cell and not on normal pancreatic cell, and no other expression anywhere else? And is it the major driver of growth, survival, or the other ones as well? We know that with solid tumors, that's often being a problem, that there are so many different drivers, proteins that can be involved in the growth proliferation.
Yes, that's true. Like you said, MUC16 is a very unique target. It is only expressed in the pancreatic cancer, not in the normal pancreas in the first place. Second, it also normally expressed in the reproductive organ system. The way we are going to treat it will not reach the extracellular, like in the either in the ovary or in the lung. Also in the lung, in the normal lung, also expressed inside. So when you infuse with the IV, it will not reach there. So we don't need to worry about the off-target effect on this case. And then the second question you said, what is the other question you said?
Any other drivers besides MUC16 for pancreatic?
Cancer, yeah, that is
tumorigenesis?
number one is like KRAS mutation. Like the KRAS is the one of the number one driver for the pancreatic cancer. Right now, they are like the MRTX is in the pipeline, like a KRAS G12D specific inhibitor. So we are thinking like this is also downstream target of KRAS. Maybe we can combine the two. Like you can see is there any better prognosis.
We've done that with myeloma. We combined GPRC5D and BCMA in one antibody because a trispecific. It has phenomenal responses in these patients.
Great, yeah, that's a
Two antigens with one antibody.
Oh yeah, that's right. Jason, yes.
Facility, I think. But the question I have is, what's the FDA going to require in terms of toxicity? Kind of leading off the last question, because if it's not overexpressed in the pancreas and you haven't seen any toxicity with the mouse antibody anyway, what do we do? Do we get some monkeys and give them it? Is there cross-reactivity? What's your plan there?
Yeah, actually, yeah, we are thinking on a pig model, like porcine model. Actually, it's usually not expressed in the normal pancreas at all. Only in the pancreatic cancer condition, only it is expressing. Maybe epigenetic modification or something else. We are thinking like maybe we can go for a toxicity is either in the porcine model or in the higher order monkey model to see is there any toxicity studies are there or not. Toxicity is there or not, then later we can move on to that patient sample. That's in the plan actually.
It would be good to know if the humanized antibody had cross-reactivity with either monkey or porcine.
Probably, but
Cells.
yeah, that's right.